Welcome back, everyone, to Einstein's Eyes, our YouTube channel. I am Carl Rosen, oculoplastics and neuroophthalmology, primarily oculoplastics in the office now. I trained at Albert Einstein College of Medicine, Department of Ophthalmology, with Ron Bird, as well as a fellowship in Pittsburgh with Jack Kennerdell, who were just monsters in ophthalmology. My partner is Jon Ditkoff. We were residents together at Einstein. And I'd like Jon to introduce himself, and then I'm going to introduce a very special guest we have today. So Jon, go ahead.
Hello, everyone. Nice to see you again. Yes, as Carl said, I'm Jon Ditkoff. I'm a cornea specialist, general ophthalmologist, Northern New Jersey. We trained many years ago as residents at Albert Einstein, hence the name Einstein Eyes. And we've been just talking about lots of different things. We started out with ophthalmology, now we're extending to medical and everything else related to medical practices. So nice to see everyone again, and nice to see you guys in Alaska.
That's right. That's right. Thank you, Jon. It's a bit colder here than it is in New Jersey, but we're tough here. So we're branching out into healthcare policy, technology, innovation, and who better to have than Mark Begich. Now, I'm going to introduce Mark, and then I'm going to let Mark run with this. But Mark was he was a state senator from 2009 to 2015, and we are honored to have him on our channel. He was also mayor of Anchorage, chair of the Assembly before that, I believe in 2013. Mark's got a wonderful family. My boy knows his boy. My wife's friendly with his wife. Mark runs Northern Compass Consultants. We're thrilled to have him. And today we're going to talk about healthcare in Alaska, specifically leveraged buyout, private equity, the state of affairs, the pros and cons. Is it good for Alaska? Where is it going? And I'm going to let Mark really discuss from a very educated policy analysis perspective. Thank you, Mark.
Thank you very much. Hey, Carl, I'm going to add a little bit too to the bio. When I was mayor back in 2003 to 2008, we were self-insured as an insurance group. We had 3,000 employees. Our healthcare costs were averaging 12 to 13% increases per year. And we had to do some things to get that under control. So my interest in healthcare has gone back, well, even before that, obviously, personally, but from a public policy standpoint. And then when I served in the United States Senate, I was one of those votes for the Affordable Health Care Act and went through a lot of pain, I will say, and agony through that piece of legislation. And I can surely elaborate on that. But I want to give you, if I can, just a quick story of my first real public policy entree into healthcare. And it's on two fronts. When I was on the Assembly, and we were insured with kind of a mix of insurance companies at that time, we worked very hard to try to figure out how do we get a handle on this. We slowly transitioned into self-insurance. And when I became mayor, we managed that. And one of the biggest drivers, one of the biggest factors in when you're self-insured, you know, basically who's, you know, what's being requested, right? Not by who, but by the volume. What kind of prescription drugs, what kind of surgeries, what kind of preventive care. You got a good sense of what's going on. And two things we introduced back then, and you got to, you know, a lot of people would say, oh, well, this is normal now, but you got to go back to 2003 and 2004, 2005. And one of the first things we did, I will never forget this. I brought in, we could tell our top 5 prescription drugs that were being purchased from our employees. So I brought in all the store managers and distributors within Anchorage. And I said, here's what we're going to do. We're going to have a new program. And the program on prescription drug is going to go like this. We're going to 90% insure and pay for as a city the lowest cost prescription for these. And we actually had 10 by that point, 10 top drugs. And we're going to reverse that. Because in the old days, what it was everyone got that. Didn't matter what the price was. I said, and any of you that are above that price, we're going to make the consumer, the employee, pay 90% of that cost. Let the consumer make the decision. Well, you can imagine their anger and, you know, how can you do that? Blah, blah, blah. And I said, because I'm the mayor, we're self-insured, and we're a strong mayor form of government. So that will start in 2 weeks. And lo and behold, and I actually used an intern to do some of the research for me. Lo and behold, can you imagine what happened? Everyone drove their prices down. Matter of fact, when Walmart kicked off their program, a lot of people forget this, their $4, $5 prescription program, that was kicked off in Anchorage, Alaska. And the reason for that was we were driving this down through a consumer decision versus them to come in and manipulate for the highest price. And as you know, prescription drugs have a very varied profit margins based on, the product line and so forth. And then the second thing we did, we said, look, we developed a website to allow people to monitor what we call their 10 indicators, health indicators, weight, intake of certain types of products, blah, blah, blah. And what we said is when you set your goal and you achieve that with our health management contractor, we're going to give you a Visa card. We don't care where you spend it. Here's $50. Go spend it on anything you want. I don't care. And here's what happened within the first year, actually about 18 months, because it took some ratchet up time. We were able to give a premium holiday in one of the 12 months of the first 12 months. So that meant in 1 month, no one paid anything, not even us as a city, taxpayers. So it drove consumers to get more in tune with their health and force some decision making that wasn't being done. Now to accelerate. And suddenly, here I am in 2009, I get into the United States Senate. Oh, by the way, they want to radically change healthcare. I mean, not just a little tweak, but just a massive change. It was probably the worst public hearings I'd ever had, and not in a negative way of sense of subject matter discussion, but it was actually very unsafe. One hearing I had, we had about 600 people, and it was not by my choice, but by others. We had undercover U.S. Marshals and police there because people actually threatened me. I didn't know all that until later, but it was amazing what was happening. As you know, Alaskans, Carl, they're not bashful about telling you what you think and what they think, and they're not bashful about physically maybe inclined to share that with you. But the thing about public policy in healthcare, as you know, imagine on the United States Senate level, you have lots of pulling and tugging and large interests and everything that you can imagine. And at that time, they were just starting to get in what I call investor mode healthcare. There was healthcare hospitals, which is different. That's always been out there, investor managed hospitals, but it's expanded quite a bit back then. And what I found was not only were the doctors concerned, which was fair, as you know, some of the primary care doctors probably the most underpaid for the work they do, and trying to get a balance there, getting more people in the pipeline, all those things that you have to do from a public policy standpoint. But one thing I think the Affordable Care Act didn't really fully address was the emerging, which was really at the beginning stages of investor-driven healthcare, private equity, large groups. People say, oh, the doctor groups. No, that's different. Doctor groups are different than private equity, leverage buyouts, investor grade type of healthcare. And I think today there's a lot more of that than ever before, and it has impact. I do, as you know, Carl, I not only do all the public policy, my wife and I employ over 300 people in 4 states, run a variety of businesses. And, as a business person, you have one goal: to make money. That's what you do. You're not a social service worker. You're not doing a project to just say, oh, that feels good today, I lost a bunch of money. You do it to make money for you and your investors, create a quality work environment, all those things that make the business successful. Healthcare is radically changing. It's getting consolidated, which some might say, well, you have to in order for it to survive. Well, you could argue yes or maybe no, because did we design a system that forced it into consolidation, or was the system going to consolidate anyway? Or another example, this one I did when I was in the U.S. Senate, this will be not surprising. National Institute of Health, one of the largest investors in beginning stage development of drugs and science related to other elements of medical care, but a lot of drugs. In my third year in the Senate, 2011, 2012, that session, I did a research paper out of the Congressional Research Office. Now imagine the most risky investment you can make in drug development is in first stage one, right? Development, the research. The next stage 2 and 3 in commercialization, commercialization is, the risk is, I don't want to say minimal, but it is less. So what happened? Well, in the year that I asked for some data, I said, all these drugs, we've done all this first stage investment. What happened? What's the return that the taxpayers got? On an annualized basis, the United States government in that year was receiving a little over $30 million a year. That's it. On all the drugs they did stage 1 development on. Now, I don't think most of the universities are receiving that kind of money, but the money was predominantly driven by National Institute of Health. So I suggested something in the Affordable Health Care Act. I said, hey, if we're the investors, why are we not the private equity fund, right? Why are we not the venture capitalists? Really, that's what National Institute of Health is. We're venture capitalists, right? We're investing in drugs that no one wants to do. But once they become successful, they throw us over the edge and say, we're going to make the money. So my suggestion was simple. Okay, let's say that drug is successful, whatever that drug is. Any government program, VA, Medicaid, Medicare, Indian Health Services as examples of the 4 major programs. And then, of course, Federal Retirement Program, which is a huge medical program. We should get those drugs at cost. We invested. We're not going to ask for a 22% return. We're not going to ask for a 3-to-1 ratio on our investment. We're going to ask for a long-term percentage partnership. And whatever they do next is their business. Oh my, this is where I knew, think about this. This is where I knew that there was investor groups very nervous about that kind of public policy. So I want to tell you those stories because I think it's, public policy isn't as simple as, oh, let's get everyone healthcare and it's all going to work, right? Or let's make sure we can provide educational supplements to individuals that need to get an education and go and do college education, become doctors or physicians and PAs, whatever. It's really about this ecosystem of healthcare. And as the largest single investor, and it is a fact of consumer in healthcare, if I was a private equity fund, what do you think I'd be able to do? I'd get great returns. I get 3 people on the board. I drive the train. We are the biggest consumers, the largest market power, and we get the least benefit. This is my opinion. Now, I'm sure some that might watch this, I'll get some calls. I'll get people I do work with call me and say, how could you say that? And we do work, and just, be frank with you, we do work with some private equity funds, even sovereign equity funds, which don't forget those equity funds. They're huge, huge. And they have market power. That's unbelievable. But I just wanted to give you those because I think your viewers and listeners need to understand it's not just about getting access and affordability to healthcare. There's a lot behind it that's driving this hope and dream of affordability for all that is costing and also access. So I didn't mean to ramble on there, Carl, but there's
No, that was brilliant. That was
Here's
brilliant.
for discussion.
No, that's brilliant. And John will chime in too, but I mean, so I think there's a number of terms that we need to think about. One is capitalism, 2 is social networks. 3 is we have to remember that US healthcare expenditures are 18% of GDP in 2021. So this is huge numbers. So this is why, private equities, which I believe in the private equity funds controlled their AUM, their assets under management at 2.6 trillion in 2021. I think that number needs to be recognized. But, fast forward from the ACA, the Affordable Care Act with Obama to Biden with the Inflation Reduction Act. And, the PBM, the pharmacy benefit managers, the formularies, the consolidation of which drugs can get out there, how they're being spent, insulin at $35 caps, all these things really evolved and matured from where you were in 2009 to 2015. And it's just a reflection of the complexity of the healthcare space, which is a dominant space in with regards to the GDP and the economics of the USA, the largest in the world, and the rest of the planet, because people look to us. So, you know, I
And
mean,
biggest job creator. When you think about the job impact in a community, you think about Alaska, Carl, rural Alaska, hospitals are some of the largest drivers of the economy, cash economy. As a lot of people may not realize, in Alaska, in rural parts of the state, you have subsistence, which is living off the land, but you also have a partial cash economy. The cash economy, and you take Nome or Bethel or any of these locations that are rural, they're big drivers because they bring cash into the economy. And yet, if that hospital wasn't there, that community would be suffering. But on the flip side, it's not cheap.
no, it's not. It's not. And I mean, there's a lot of latitude there. That's a whole nother discussion, but just for our
Right.
audience, I mean, right. Our audience needs to know that in Alaska, there's sort of a triumvirate. There's the native system, which is sort of separate and well-funded, the government system, military, we have Elmendorf, Fort Rich, and then the private sector, non-for-profit, for-profit. We have Alaska Regional Hospital, which is HCA, largest hospital enterprise in the country, as well as Providence, which is a large hospital enterprise in the Northwest, California, Idaho, New Mexico. And, you know, it's a complex web. I do think, I mean, I'm biased. I do think we have a good medical community here. There are some limitations, but overall we do. People would argue as far as cost containment and value, but you know, how, and we've seen private equity in Alaska. So you know Providence well, you know ARH well, you know Fairbanks, Juneau well, you know the players. How do you see private equity, leverage buyout, again, which is using a debt instrument against the practice assets, which again is something that's not fully understood, I think, by the MDs. There's a supply and demand issue here. But how does that affect our community's ability to take care of patients?
Well, first off, private equity, they're never forget their goal. Their goal is to get that bottom line to go up, right? Because they have, no matter what they pay for it, they got to sell it in 5 years or some period of time after they invest for more. They're not investing to sell it for less. Don't be confused there. And I don't begrudge them. That's their job, right? That's their investors. Their
Right.
job is invest and get a return, and their returns can be 12, 15, 20%. The higher is more likely. So the first thing they do is they look at when they buy out a practice or practices, or they try to, I don't want to say control the market, but that's their goal, because they have to be careful because the Federal Trade Commission and other things, and the oversight that could happen immediately, CMS, all these regulatory agencies that watch the consolidation and control the marketplace. But there's been less enforcement on that end. So there's been more of this happening. And I say this in a both positive and negative way. As someone in the private sector, I hate the federal government, state government, local government, always on my back on whatever, who knows what. But on the flip side, they're balanced, right? They're trying to watch the consumer component. Now, saying that, when that happens in private equity, and if anyone wants to argue this with me, I'm happy to open that up, but they got to make money. So they're going to look at the system and do 2 of 3 things, maybe all 3. 1, increase revenue. Now that means looking at what they've been doing. How do they increase that? What are the new services they might provide? What do they do in that area? Employees. How do they consolidate, squeeze, get more time or less employees? Quote, efficiencies. And 3, at the end of the day, how to limit their own capital if they use debt, because debt is someone else's problem in the future, right? So it could be 1, 2, or 3. More than likely, it's definitely revenue and expenses they're going to look at immediately. And they probably saw some lost opportunity. That happens. And that revenue stream, they'll try to expand their market share, buy up others, consolidate the market, control the pricing. Then they'll look at what other product lines they want to produce. And some of it may be you're in there and next thing you know, you're getting one kind of product, but then there's three other things they recommend to you. Now, maybe it's not mandatory, but you decide, well, that makes sense. Maybe I should do that. But it has a higher profit margin, right? It's like, and I hate to compare this, if you're in a restaurant business, getting the meal is great, but the margin's on the liquor. Do not confuse yourself. So they don't come back to you multiple times, say, did you want some more fries? Or more, another salad. They go, would you like another drink? Right? Maybe soda or liquor. They all have the margins that are pretty significant. So they will look at that. And what it does when you start, and a good example is, they might consolidate their call center, their helpline, their nurse line, the nurse line that, I know I do it. I'm sure you guys do it. You call up, the nurse might ask you several questions, kind of figure out what you might need before the doctor gets on or may not ever get on. But that doesn't have to be in Anchorage. That can be anywhere. It can be a nurse call center somewhere, wherever. Because now the problem with that, of course, is, John the nurse you knew or Jane the nurse you knew, they don't exist. They're on something else,
No, 100%. Yep.
And that is the frustrating. And when you're in a need of healthcare, and again, you guys know this better than I do, you're not calling to say, hey, how's it going? Things are great with me. I'm just calling to check in. No. You're calling because you're sick. And so you're already a little bit miserable. You don't want to call in. I mean, I just had a root canal last Friday. It's not something you get excited about and say, hey, I'm just calling the dentist. How's it going? Good patients this week?
Right.
No, I'm calling because my tooth is killing me.
Right.
So now when you call and it rings and then someone answers says, well, I don't know your case. Well, let me get back to you and blah, blah, blah. Versus I could call my dentist or doctor and it's, oh yeah, Mark, yeah, you bet. Let me get your chart. Yeah, we worked on that last week. You were here. Healthcare, and again, you know this better than I do. Healthcare is personal. Mental health care is even more personal, right? So it's about your relationship with your physician, may be whatever that delivery system is, but also it's your relationship with the nurse, the physician assistant, even the billing person, who calls you and says, yeah, we got to get you on a payment plan. We can't, we got a challenge here. And so it's really
Mark,
the private equity funds could divorce themselves from that personalized touch,
right?
Which, they're about making money.
Yeah. And remember, the managers of the private equity, they're managing other people's money, limited partners. And at the end of the day, they want an increased EBITDA, earnings before interest, taxes, depreciation, and amortization. And the way to do that is not so much better patient care. It's just to consolidate and do those roll-ups. So the EBITDA is bigger than it was when they walked in.
That's right.
And I think, John, we had this conversation before, and John, he gave a brilliant example, where a patient calls in, before private equity, the doc would answer the phone. After, he's not there, because the check's been written, and now he's an employee for that organization. Yep. I do want to say one other thing, and you guys can jump in, but I've listened to podcasts and interviews with academicians and economists who talk about private equity, and they're, I would say, maybe not universally, but they're much more positive on it than folks who are in the trenches like myself and John, because we see what happens. Now, it can be very good for some older physicians who want to exit soon, but for the younger folks who just, finish residency or within 5 years of residency, it's really not a good deal. And there's this chasm between the academicians at these, world famous MBA institutions and other universities and economists and guys like John and I. And I just sort of chuckle at the conversations because I wish they would come and visit and see what it's like to actually be in front of a patient, listen to them, worry about their condition, worry about their medical imaging, their lab tests, whatever else, to come up with a diagnosis, an assessment, and a management plan. So I don't know, I highlight that because it's just something that I've been thinking about. But Mark, so this has been brilliant. John, is there anything that you want to add?
Yeah, I mean, I'll say a few words. First, I want to thank Mark. I should really say senator, once a senator, always a senator.
Thank you.
So I really do. I think I knew a lot about this before. Your perspective and your historical perspective was really great. I mean, it was great to hear all of that. One thing you said about consolidation, to me, like at least in New Jersey, what I saw was there were less and less insurance carriers. So the insurance carriers were gaining more and more control. They weren't competing. They gained a lot of market share. They were controlling rates. So a lot of docs that were on their own, one or two docs in a small practice, they felt a squeeze. The insurance companies every year kept lowering reimbursement or at least freezing it. And what I think a lot of docs in this area felt compelled to do was to join larger entities to get better rates. And to your other earlier point, how does private equity, how do they turn a profit? What can they say to a doctor's practice? So I think one mistake they make is they go into some mom and pop medical practice where they think, we're going to run this better. We're business people. We know what we're doing. That they're not successful at. I mean, you're going into a practice with a guy who's been running a practice for 25, 30 years. I mean, he knows how many pens he buys per year. He knows where he gets his paper. I mean, he's getting the best deals on every lab supply. So yeah, these big companies think they're going to just buy in bulk and do such a great job, but they're hiring employees to do this. These guys don't care the way a mom and pop small owner does. So that's where they failed. The second area where they failed is they think they can grow the business. They think they're going to get these doctors to work harder. That's not true. When a doctor is working for himself, he's working 8 in the morning to 8 at night, 6 days a week. When you hire some guy out of training, they want a good lifestyle. They don't want to be there after 5 o'clock. They don't want to work on Saturdays or Sundays. So that's another area they failed. So the big area where I think they have succeeded to some extent is rates. So what they do is, to Senator's point, they consolidate a bunch of practices, and then they go to a health insurance company and they say, listen, we're negotiating rates. We have a seat at the table compared to this guy by himself. And now the insurance companies have to listen. But at the end of the day, what is that doing for the consumer? Nothing. These guys, it's just an extra layer of someone else that needs to profit. You have the insurance companies, you have the hospitals. Now you have this other entity that needs to profit. So what is it doing? It's actually driving costs up. And for these private companies that need to insure their employees, they can't afford it because either they're paying the insurance companies rates or they're paying the private equity rates. It's insane. It's a no-win. It's just going up and up and up. And who's losing the consumer, the patients? So my last point is what Carl said. How do I know about private equity? I'm not part of private equity. I know it because I'm a consumer. I'm a patient in Northern New Jersey. My doctors that have either sold out or joined the hospital or the private equity, I can't reach them. They say, try the portal. The portal doesn't work. I call after 5 o'clock. Nobody answers. I call at 4 o'clock. They say they'll call me back. They don't call back. No one ever answers the phone. Nobody. So I think that's my biggest gripe as a patient. The doctors are still wonderful. Some of these guys are my age. They've been doing this for a long time. They're very experienced. They're caring doctors. But now it's just not the same.
But John, I will just say this, and my final thoughts on it, and that is, your point is well taken in a lot of ways, because what you just said is what healthcare is about is relationship development with your patient. And, you'll see study after study when people feel better, not just physically, but I mean, mentally better. They have a relationship. They feel like someone cares about them. That's why a hospice is such a great program in many ways. That in a clinic or in a hospital, you're at home with family, as an example at your last parts of your life, but also there's this whole study that talks about in-home care and what the value is of that, because you're around family members. 2 things I recall when we did in the Senate. One, we made sure the 85% rule, and a lot of people don't know what this is. They get checks. Everyone gets these checks from the insurance company. They go, what is this for? Well, because they charge too much. And we're only going to allow, by law, a certain percentage goes to their overhead, but the rest goes to healthcare. And people get these checks. They have no clue what they get them for But really what that is, because federal law prohibits these insurance companies from profiting at the levels they were profiting at. I'll never forget this story. When we passed affordable healthcare, got close to it, I went on to E-Trade, ran all the corporate stock prices for the insurance companies over a period of 4 or 5 weeks prior to that. And I delivered those to the White House in printed form because I was so agitated. And I said, this is the deal you cut with the insurance companies. See their stock prices? They all went up. And I said, because you limited their cost and liability with one single act of public policy and shifted the burden onto the federal government, the taxpayers. That's just a fact. Now, insurance companies can argue all they want with me, but I can show them the exact. Now, people say, well, there's always, when you do something, there's always, a cause creates an effect, or when you do something, it has an effect. Yes, it does. I can't contribute at all to that, but it was very interesting to watch during that period what was happening in the marketplace. And lastly, people have to always remember, if they have never read the book about J. Rockefeller, or not J. Rockefeller, but John D. Rockefeller, they should. John D. Rockefeller understood one thing, and so did Gould and these other guys back in the day. What they want to do is consolidate the markets, vertically integrate in order to manage and control pricing to get the maximum profit, which is, hey, good for them. But then the federal government stepped in and said, whoa, a little too much.
Yeah, too
And
much.
because the consumer was now paying the burden, and the end result was the quality of life of a country was stagnant or going the wrong direction. And so we have to remember that about healthcare. Carl, your point at the beginning, 18% of the GDP, it is a market mover. And if there's one thing that if Congress would, and I can say this, get off of there and I'll leave it blank and focus on these kind of things, the consumer would be better off today focused if they were focused on this. When it drives that much of the economy, we should be looking at every element. And it doesn't have to be in conflict, but it should be in a way that allows more flexibility so we have more entries into the marketplace, create more competition, and then allow, if doctors want to own their practice, so be it. Give them some incentives to do that. Private equity wants to own it, great, but you're going to have some caps and control of costs. Because at the end of the day, everyone will say this will be better for the system. Okay, great. That should be lower cost, more accessibility, and more innovation. That's what's good for me. That's what's good for you. That's what's good for Carl, right? But
Agreed.
that's not what usually happens. When they improve good in the last one, I'd say when they tried to improve Coca-Cola and say we got new Coca-Cola, it was garbage. They wanted to tell us as a consumer, no, it's better. The consumer said, no, we're not buying that junk. And a lot of people forget there was a thing called new Coca-Cola. So
Yeah. No, so brilliant, John. Excellent. Senator, brilliant discussion.
thank you.
So I do want to inject one thing, but we're going to save this for another topic, another session, and that is how AI will affect this.
Oh,
Because now we have a binary system that removes potentially the bias, the emotional component, and if done correctly, and I hope this is done correctly, will still allow for some belief that the system has the best interests of me, the patient, in mind, and that there's trust. Because Mark, you were getting at this, the relationship issue is about trust. When people come and see me, they trust me or they wouldn't be there,
that's right.
and
Great
the
point.
referral network is established because one guy will say, John will send a patient to me and say, listen, I got this guy, he's great. He's a little peculiar, he's a little odd, but he really knows what he's doing. He's great. And you just got to trust him. Listen to what he says. And people walk in and they already have a smile on their face that they're there thinking that I'm smart. I got good hands. I know what I'm doing. As opposed to, just you're in another country, you walk in, you don't know who this guy is or this gal is, and you're already a little bit itchy about that,
That's right. Yeah, I call AI, there'll be great conversation at a later time, but AI is like algorithms on steroids if not done right.
Right.
And it's just mathematical. And the last thing, you made a good point, and that is when I had my eye surgery, had LASIK, I didn't want the guy who had just done 3 of them. I wanted the guy who like changes my tires in my car, does it without even knowing he's doing it, right?
Yep,
It
yep.
is
Great
second
analogy.
nature, right? And
Yeah.
you're flipping those tires. And I actually asked, it's kind of like, how many have you done? If they said to me 3 and they're new to town, I'd be very nervous, right?
Yes,
But if I
100%.
got a recommendation from someone, I said, go to this guy. He's really good. He's well known. Yep, he has some weird parts of his practice, but don't worry about that. His hands, his ability, his knowledge is the best. And that's what I did.
No, that's great. And I'm totally, I support that. Yeah. So, so thank you, Mark, Senator.
Thank you guys.
Thank you, Counselor.
Councilman.
John's a
Councilman.
counselor
No,
in New Jersey.
I've learned from a close friend of mine that's an assemblyman in New Jersey. I was mayor for a very short while. Every time he sees me, he calls me mayor. I said, I'm not the mayor. He says, once a mayor, always.
Always. John, they call me that today still. And doesn't matter. I was a U.S. Senator. Mayor is more important.
Yeah, cool.
And think about this.
Mayor of Anchorage is big deal.
Big deal. When you think of legislative bodies, state legislatures, federal government legislatures, and local city council, there's only one that faces the people during their debate.
Oh, yeah.
That's local government. You face the people when you talk about what you're about to do. State government looks at the speaker. The federal government looks at the speaker or the president of the Senate. They don't look at who's there in the audience. So remember always that.
But don't forget, Mark, I mean, you've done so much that it gets confusing. Chair of the Assembly, Mayor, Senator, I don't know what to do. But
My name's
but
Mark.
right. No, but listen, thank you.
Thank you.
Mark, please accept our invitation to come on and talk about AI and healthcare.
That was really great.
Yeah, you're a brilliant speaker. We had a great session today, and we look forward to another one.